officially, maybe I should introduce you, but I think I'm going to let Jesse do the introductions today. Are you okay with that?
Oh, geez, I knew that was coming. Sure. Hi, everyone. Today we have the pleasure of having one of the fathers of the field of controlled vocabularies in biomedical informatics, or in biomedicine, talk about terminologies and what they can do, how they're important and what they can do for us in the mental health space. Dr. Cimino is the director of the, let's see, I was looking at it, I guess the Informatics Institute, something, I can't see your thing now, but at the University of Alabama at Birmingham. Very exciting things going on over there, formerly at Columbia and NLM, and I think that covers the highlights. Jim, what did I forget?
No, that's good. Except that I prefer to be called one of the parents of informatics, not father.
Not the father?
Just a parent.
Very progressive of you.
To gender neutral, as you'll see later in this talk. This talk is kind of cobbled together from some other talks that seem to cover some of the topics that Piper said you'd be interested in. So I apologize if some of it is too basic because and I'm not a mental health expert, so that part is I'm taking some examples that Piper shared with me, and they're more intended to lead a discussion, and we'll try to see how well we can do a discussion in this context. So let me jump into this and tell you a little bit about controlled terminologies, or controlled vocabularies, I should say, and see where that gets us. Okay, so I'm going to talk about something called desiderata for controlled terminologies, and I do screw this up. It should say controlled vocabularies because controlled terminology is redundant. A terminology, by definition, is control. We'll talk a little bit about good versus bad terminologies, and then some SNOMED examples and that are relevant to mental health. Okay, so first, controlled terminology. So this is a list of airports, and you see those little codes on the left-hand side. That's a controlled terminology. We might have different names for airports. Some people call the airport outside Washington, D.C. National Airport. Some call it Ronald Reagan Airport. But if you want to fly there, you put in DCA, and you're going to get there. If you put in the wrong letters, you're going to end up in the wrong airport. That's a controlled terminology.
Jim, I'm not seeing. Are other people seeing the slides advanced? I'm still just seeing the title slide.
Oh, no, that's interesting. Yeah, I see that you're seeing that. I don't know why that is. Oh, I bet. Is it sharing? Let me see what it's doing. Sharing screen 1, main monitor. Clean. Let's do this. How about that?
There we go.
There we go.
Perfect. Yeah, that's good.
Okay, so that was the clean monitor screwed me up. All right, so there's my airports. You didn't miss much. Some of you may remember this thing, the C prompt. This was in DOS and maybe some other operating systems. And what you type after that was a command to the computer, and it was a controlled terminology. You could say print or directory or run or format. You couldn't just put in anything you wanted, but you could also write your own programs and give them names that would then be part of the controlled terminology. And then this is a Burger King. And it turns out Burger King and their ilk have controlled terminologies as well. I was in a Burger King, and a guy in front of me was trying to get the nuggets, chicken nuggets, and he kept calling them chicken McNuggets. And the guy behind the counter kept refusing to tell him that Burger King doesn't sell chicken McNuggets, but they do sell chicken nuggets. Would you like that instead? The guy just kept saying, we don't sell those. And the guy's very frustrated. And finally, I tapped him on the shoulder. I said, this isn't McDonald's. They call them chicken nuggets here. He said, oh, okay. And he ordered his nuggets and went on his way. And then the guy asked me what I wanted. I told him I wanted a Big Mac. So that's controlled terminology in the real world. In biohealth, we can, I try to pick some simple examples. So this is a 2008 census dress rehearsal form that I found once upon a time. It's very useful because if you look at question 6, it says, what is person one's sex? And you have 2 choices, male and female. It's going to be interesting to see what the form looks like this time around, but that's what it looked like in 2008 or 2000 for the 2010 census. So that's a controlled terminology relevant to healthcare, male and female, gender or sex. And so that's a pretty simple terminology. It's got two possible answers. A terminology that only has one answer isn't particularly useful. You have to have at least 2 terms, and there it is. That's about the simplest one you could get, and even that's really complicated. This is a bill from a hospital, and these are all controlled terms. They're CPT terms and things that come from a controlled terminology. And then this is a controlled terminology too, although it might not be apparent. You can try to guess what this looks like. Some people will say it's Mellaril, but it's actually Wellbutrin. And so some people can read this, but what's on there is a controlled term from a controlled terminology, controlled vocabulary. All right, so why do we have these things? So you can think of them as a special value type. So something that we're trying to fill in a slot in a form or a field in the database, and sometimes you could put in numbers, sometimes you can put in floating points, sometimes you could put in short text or long text, and a terminology provides special value types so that you limit what you can say, but you have hopefully a useful set that helps people capture things and be able to say them in a consistent way. If you do it right, you want to be able to reuse these things across parts of the data set. So for example, if you have a terminology of diseases, and imagine, let's take a simple way of implementing terminologies and think of a web form where there's a pull down. Each of those pull downs has choices that you're forced to pick one. That's a controlled vocabulary. And if we had something like disease, and so there's a field where you check what your disease is, then there's another field for family history, and you would pull down a different list of diseases. Hopefully you would reuse those diseases across both of those sets. So reuse is one thing that's useful. It constrains what can be said, which seems like a bad thing because you want to be able to say, you want freedom of, it's probably a First Amendment or something thing, that you want to be able to say what you want to say. But if you're left loose to say anything, then the receiver of that information might not know what you're talking about. So constraining what we say helps. So when we talk about gender, for instance, if we decide what we mean by male and female, then we can hopefully share information in a consistent way. So there's the consistency point. Okay, what happens if terminology is bad? Well, it depends what you're doing with it, but it certainly means that you won't be able to record data in an accurate, reproducible way. The meaning will be unclear to the people who are looking at it. You might make mistakes in doing inferencing. So if you put in the wrong, if you have a disease term that's not accurate, you say, for instance, oh, the patient has diabetes, you might make some inferences about what that patient has, but maybe they have diabetes insipidus and not diabetes mellitus. So you can have problems with inferencing, which if you have decision support in your system may cause you to order the wrong test, make you interpret the test incorrectly, pick the wrong treatment, make mistakes in your research, or if you're doing something simple with a thing like gender and putting people in hospital rooms, you might put them in the wrong room. Okay, so isn't this problem already solved? It seems like it should be. And actually maybe we're getting there. We're starting to get there in some ways. But what happens is that people find that it's easier to build their own terminology than to standardize because of this not invented here syndrome. That is, somebody else created it. I don't really understand it. It doesn't have exactly what I need. So I'm just going to make my own because I can't deal with what everybody else has created. And there are standards, but we don't have agreed upon standards to be able to translate between. We don't have a way to translate between them. So if you pick one standard and I pick another, we have trouble exchanging information. Maintaining terminology costs money, and a lot of times people don't think about that. They say, okay, we're going to create our application. Here's the terminology it uses. And then later, somebody says, oh, we need to add a new thing to this pull down. Or we need to, expand the list of diseases. New diseases have been discovered. New drugs have been added. New lab tests. We need to do things. That costs money, not just in terms of finding somebody to go and add it to a file somewhere, but making sure that it's added in a way that's consistent and doesn't break the things that you have already. And we'll talk a little bit about that later. And then there are often proprietary interests. So some terminologies have licensing fees associated with them, and that's hindered adoption. So the real problem, though, is that modeling the world with a terminology is hard to do. That you want to do it for what I refer to as symbolic manipulation. That is, you say something about a patient, you say, okay, this patient is male or female. The computer can record those letters, so it could record a code, but it doesn't have any underlying understanding of what that means until or what to do with that information unless you tell it that, well, somebody who has this gender code should get a mammogram and somebody who has this gender code should get a prostate-specific antigen test. and then you have some way to model the world. And as we'll see with gender, even gender, simple, binary thing, gets hard to do. All right, so a little history where this desiderata thing came from. 1994, I was at an EMEA Working Group 6 meeting in Montpellier, Switzerland. That's overlooking Lake Geneva. This is the Hotel Mirador. And the Europeans really know how to have conferences. So this was where they had this terminology conference. So pretty dry topic, but in a very nice place. And there was a guy there who ran the meeting, Jean-Louis Charest, who heard me do this presentation on terminology. And he said, hey, that's an interesting topic. You should write a review paper about what everybody's doing on terminology. And so I said, okay, you didn't say no to Jean-Louis Charest. And I also didn't know how much work it would be to go and research the literature. Part of the problem with doing this paper was that everybody used different terms for everything. Even hierarchy had all kinds of different names. So trying to figure out what people were talking about and when they were saying the same thing and something different was kind of challenging, especially when I couldn't reach out to them, figure out where they were, and talk to them. But the result was a paper that got presented at the next EMEA Working Group 6 meeting, and this is in Ventana Beach Hotel I'm blanking on the town near St. Augustine, Florida. And so again, this one was hosted by Chris Shute, and I presented this paper, Desiderata for Controlled Medical Vocabularies in the 21st Century. And the idea was, originally I sort of pulled together what everybody was doing when I found these repeating themes, and I said, people keep saying they want this in the terminology, let's make a list, and that's where the Desiderata came from. Okay, so I'm going to go through some of them very quickly, and then I'm going to talk about SNOMED in particular, and then we'll take a couple of mental health examples that Piper shared with me, and then we'll have some discussion. But let me just blow through about 5 or 6 of these real quick. So the first desideratum is content. And it used to be that was the only one that anybody cared about. They would just say, oh, my terminology is better than yours because my terminology has this term and yours doesn't. And so people go, well, I'm going to add it. Now it does. So now my terminology is better. And the idea was just keep adding terms to your terminology until it's big enough, and then you're done. And it didn't really work that way because people started adding things that got confusing. They messed up the hierarchy. They would add things that were sort of similar in meaning to things that were already in there, or it wasn't clear why they added a new term. And so without an editorial process, just adding terms to the terminology doesn't work. That said, you want to make sure you provide the breadth and depth of the domain that you're trying to cover. And then you also want to make sure that whatever structure you use for your terminology, whether it's hierarchical or just a list of codes, you want to make sure that it doesn't limit how big the terminology can get. And I like to pick on the ICD family of terminologies because they sort of violate almost all of these desiderata. And one of the things they do is they have this code structure that limits how many things you can have at any level in the hierarchy. So what's needed for high quality terminology is a formal editorial policy and methodology for how you add things. And the way things got added to SNOMED, for instance, was that people would send postcards or letters or whatever to Roger Cote up in Sherbrooke in Canada and say, hey, Roger, you're missing this term from this terminology from SNOMED, and he would add it. And he would just do that over and over again and the thing was humongous, and he didn't have any way to say, where should this go? It would just be wherever that day he felt like it should go. And so that caused a lot of problems for SNOMED. Now, this is probably the most important of the desiderata, and that the idea of concept orientation. The notion that it's the concepts or the meanings, not the terms, that are the unit of discourse. We're trying to convey meaning, and the names we use for these things are not as important generally because we're trying to, the names can, they can have different languages, they can have synonyms. It's underneath, it's the thing that we mean, that we're talking about. If we're talking about a disease, we want to make sure we know which disease we're talking about. So if we have 2 different names for it, that's fine, but we need to know we're talking about the same thing so we can give the right treatment, do the right testing, and so on. So there are a number of aspects to concept orientation. One is that you don't want to be vague. You want to have at least one meaning per term. So My example of diabetes by itself isn't really a useful controlled term because we have diabetes mellitus and diabetes insipidus. And those have nothing to do with each other. So there isn't even a class called diabetes. So diabetes, the term as a term, is a vague term, has no precise meaning. Non-ambiguity means that you don't want to have more than one meaning per term. So ambiguity is an ambiguous term. It can mean you're not really saying anything, or it can mean you could mean multiple things at the same time. So either way, we want to avoid ambiguity. We also want to avoid redundancy. So we don't want more than one term in a terminology that has the same meaning. So synonyms are okay, but you don't want to have redundant terms. Related to concept orientation is the idea of concept permanence. And this is where maintenance comes in. So once you have a term in the terminology and you start recording data with it, you got to be very careful about thinking about deleting that term from the terminology. You can't just delete them if you have data that are stored with them. Somebody died of a disease, you can't suddenly decide that disease didn't exist. They had something, and what we called it at that time was maybe as good a name as we have. We're not really sure what they had because we didn't have a good test for it or what have you. But we have to acknowledge that there was some meaning associated with that, with those data, and we want to keep track of that meaning, even if we decided that it's outmoded. So non-A, non-B hepatitis is an example I like to use because there used to be, we knew about hepatitis A and hepatitis B, and then we found that some people clearly had viral hepatitis that wasn't A and wasn't B, so they called it non-A, non-B. Eventually, we got a test for hepatitis C, and it would be nice to say, oh, all those people with non-A, non-B really had hepatitis C. But in fact, there are other viral hepatitis that are not C and not A, not B. So somebody who died of that, we can't say simply that they had hepatitis C without going back and testing the specimen to prove it. So we have to maintain this term in our terminology for historic reasons, but that doesn't mean we have to use it. We can retire it or mark it as what Randy Miller called emeritus. So it's just a term that's outmoded. We want to maintain it because it did have a meaning. So now we can change the names of terms that are associated with the concepts, but we can't, as long as they don't change the meaning. So one example is a retronym, and my example is transvenous pacemaker. So a transvenous pacemaker, you probably know, you take a wire, you stick it in a vein, you thread it through the vein to the heart, and then you can pace the heart with that wire, and then you put the pacemaker wherever. If it's internal, you put it under the skin, and so on. Well, it didn't used to be called a transvenous pacemaker. It used to be just called a pacemaker, because that was the only way you could pace the heart. And then you developed transcutaneous electrodes. You just slap it on the chest and you can actually shock the heart through the chest wall. Those are transcutaneous pacemakers. So we needed to go back and rename the pacemakers we had before and pacemaker terms as transvenous to make it clear what we were talking about. Didn't change the meaning. That was always the meaning, but it was implied rather than explicit. So there are reasons we can change term names. Just have to be careful not to change the meaning, and I'm going to talk about that a little bit later. So just the example of retired concept. So here's my viral hepatitis hierarchy, and once upon a time we had A, B, and non-A, non-B. And then when we added hepatitis C, we can retire non-A, non-B, but hepatitis C actually becomes a child of non-A, non-B. So if I wanted to say, find me all the people that have hepatitis C, then I'll look for that code. If I say, find me all the people that have non-A, non-B, I can find people with that explicit code, but I can also pull up the people that have hepatitis C because in a way, they fall under that class. Number 4, non-semantic identifier. So the identifier is a shorthand thing that we use for a term in a terminology. And sometimes it's a code number, and sometimes it's a sequence of letters. One thing you want to avoid doing, don't use the name as the identifier. That is, don't say, I've got a list of terms, and here are their names, and just put the name in, and that's it. If you do that, you have a problem when you go to maintain the terminology. If you try to change the name from pacemaker to transvenous pacemaker, you now have two terms two codes that have the same meaning. Also, for the similar reason, you don't want to use a mnemonic. Mnemonics seem like a good idea, and by mnemonic I mean sort of a shorthand thing. And clinical labs love to do this. They'll have a code for a test. They'll call it Gluck, and Gluck 1 and Gluck 2, and you go, okay, so is that glucose or glucagon? And later they forget they used Gluck and they'll call it glue, And so, the mnemonics run into trouble as well. And you don't want to use a code that'll run out of room, like ICD was an example of that. And hierarchical codes are very tempting, like ICD. They're very tempting to use because they let you show not only an identifier, but a class, and you can kind of tell from the code where something belongs in relation to other things in the terminology. It's very tempting, but causes trouble when you need to move things around. So in ICD, they decided to move peptic ulcer disease out of the stomach diseases and into the infectious diseases. And when they did that, they had to delete the old code and create a new one because there was no way to simply move it in the hierarchy without changing its code. So what a lot of current terminologies do is they'll use a meaningless integer, and maybe they'll have a check digit, and also try to avoid using alpha characters. So especially O and I and 5 and 2, and there are 5. They get mixed up with the letters, and so S, what is it, or S or Z. Of course, ICD uses letters because they like to violate all the desiderata. All right, number 5, polyhierarchy. So lots of names for polyhierarchy: directed acyclic graph, or DAG, partially ordered set, post set, lattice, multiple hierarchy, heterarchy. I chose polyhierarchy because nobody else was using that, and it seemed as good a name as any. But all it means is that something can have more than one parent in and it is a hierarchy. So it can kind of be in more than one place in the hierarchy if you think about teasing out things into a tree structure. It's needed to really understand terms. Sometimes if you place a term in only one place and it belongs in two, that may limit your understanding of the meaning of that term. Sometimes you need it to find terms by tree walking. So you start with a general term in a hierarchy and then, okay, I think this is what I want, but show me if there's a more specific term. And you go down to a more specific term, and then you look for a more specific term under that, and so on. So we call that tree walking. So you're walking down the tree looking for the right term. If something belongs in two places and it's only in one place, and you walk down the wrong tree, you're not going to find it. And so that's a problem if you're using tree walking to find a more specific term. And then used for inferencing. So if you have, for instance, if you have a rule that says if the patient has lung disease, make sure you give him flu vaccine. Well, that's great. He has pneumonia, he has asthma, he has interstitial lung disease, he's got black lung. Fine, he has lung disease. What about lung cancer? Well, that's often under the cancer part of the hierarchy, and so the rule would go, nope, he doesn't have lung disease. He's got this lung cancer thing, but no lung disease that I can see. So you need it for proper inferencing in your systems. So Goodpasture syndrome, an example. Besides the lung disease, I've got Goodpasture syndrome. That's a disease in which you develop antibodies to the basement membrane of your kidneys and your lungs. So you pee blood, you cough up blood. It's a nasty disease, and it also causes trouble in hierarchies. So we can classify it this way, but really it needs to be in more than one place. Polyhierarchy. Looks very simple on the graph, but computationally can be problematic. All right, so the hierarchical coding system of ICD-10. So if we take tuberculosis, and they cleaned up the tuberculosis hierarchy a lot. It was kind of messy in under 9. Go take a look sometime. It's very odd. It's classified by how you diagnosed it, not where it is in your body, which is a little strange. So this seems like a reasonable hierarchy, and we can see respiratory tuberculosis, and there's a bunch under there, and we see other tuberculosis of nervous system, and we see a bunch under there. And so, seems like a reasonable thing. And what's very tempting is to say, if I'm looking for all the cases of tuberculosis, all I have to do, I don't have to put in all 61 of these codes. All I have to do is put in A15, A17, A18, and A19, and find me all the codes that are either those codes or begin with those codes, and I'll get all my tuberculosis because they're all grouped in this nice hierarchy. Very tempting. And in fact, one of the reasons that they do this in ICD is so that they can do queries like that. The problem is medicine is not so nice and neat. So it's actually a little messy. And so some people with tuberculosis might have sequelae of tuberculosis, and they might be classified with one of these B codes. Or they might have tuberculosis complicating pregnancy, and then they'll be under the O codes. And notice that's not a 0, that's an O. And then there's a few other ones, kicking around. These are the only ones I could find. Maybe you'll find some others if you let me know. I'll add this to my slide and give you a credit. But they are, so you can see just asking for the ACE 15 through 19 isn't going to get you everything that you might be looking for. So it's deceptive. Formal definitions. So formal definitions are structured, controlled definitions. They're not narrative like you would see in the dictionary, but rather use a formal structure that's reproducible, and they use controlled terminologies or controlled vocabularies to flesh out the meanings in the definitions. Helps understanding, of course. That's what definitions are good for. It can also help with maintenance of the terminology, because if you clearly define the meaning of something using controlled vocabulary, your terminology management system can take advantage of that and help you make sure you, for instance, put things in the right class, or that you didn't add something that's already has the same definition somewhere else in the terminology. And so we represent that, you can think about a frame representation with slots. You can think about a semantic network, different ways of relating it. But basically, it's relationships among the terms in the terminology, either within the same terminology or across different terminologies. And typically, we want to look at definitional information and not worry too much about assertional knowledge that might change over time. So by that, for instance, definitional might be the site of pneumonia is the lung, by definition. But the treatment of pneumonia changes with time. So here's a narrative definition: serum potassium test, just a test that measures potassium ion concentration in the serum. Not too controversial, but a formal representation of that would look like this, where the test is a controlled term, serum specimen is a term, potassium ions is a term, and also ISA has specimen, measure substance. Those are also terms in the terminology, and they relate things across different classes of terms. So graphically, let me just say, you can see that you could generate the narrative definition from the formal definition, but it might be hard to go in the other direction. And then graphically, it might look like this, a little semantic network showing where serum potassium test is in this hierarchy and how it relates to other things. So you can see if I come along with a new thing called K from the lab, says, oh, we've got a new thing called K. I'll go, what is it? They'll say, well, it's a test. I'm like, oh, okay. Well, if it's a test, then I know it has a couple of attributes, like has specimen and measure substance. What's the specimen? They go, oh, serum specimen. I go, okay, what does it measure? Well, it measures potassium. First they'll say, it measures K. And you go, okay, what's K? And they'll say, well, it's potassium ion. You go, oh, okay. Now I have a new definition for this new term, and I can go, hey, isn't this redundant with the term you've already given me? And they'll say, yeah, but we don't care. All right, last one is NEC, and the desideratum is avoid NEC. NEC is stands for not elsewhere classified, and this is a shorthand that you'll see in terminologies, especially the ICD terminologies. It basically means, okay, we ran out of room, we ran out of imagination, we got tired of creating individual codes, for whatever reason, we stopped enumerating all the things that we wanted to say, and we just create this catch-all. Or we can use this catch-all later if something comes along that we didn't anticipate, and you can just use this catch-all. And then, again, very tempting. And in fact, when I presented this paper at that conference in St. Petersburg, people stood up and yelled at me. And in fact, if you look in their papers in Medline, you can see in the abstract where it says I was wrong, my name. Because they said, no, you have to have these terms. How can you have a terminology that doesn't have these? And that's a topic for another lecture, but I can do it just fine, thank you, and avoid some of the problems that you get with this. So one of the problems with this term, so it's used when you don't have an explicit code, you can't have a formal definition. Because the definition is, well, it's everything that's not in this big terminology over here. If it's not in there, then it's then it's use this term for that. What happens is if your terminology changes, then the meaning of these not elsewhere classified terms change, even though they don't look like they've changed. And it's a kind of semantic drift because you basically have removed things or added things to this category that weren't apparently there or not there before. Let me show you an explicit example. This was taken from data from the NIH Clinical Center, and I was interested in non-traumatic shock. So they have, back in 2007, Of course, we had cardiogenic shock, septicemic shock, and hypovolemic shock. But when we wanted to code it in ICD-9-CM, which was the version of ICD at the time, we only had two codes for the non-traumatic shock. We had 785.51, cardiogenic shock, and 785.59, which was shock without mention of trauma, not elsewhere classified. So if you had septicemic shock or hypovolemic shock, they got lumped into that 785.59. That was how they coded it. There was also 785.5, which you weren't supposed to use because it was what's called an incomplete code because it didn't have that last digit. But people tended to use it anyway. Well, in 2008, the powers that be decided, septicemic shock seems like an important thing. Let's create a code for that. So they did, 785.52, and they called it septic shock. So now when we had somebody with septicemic shock, we have a code for that. So what I did was I said, find me all the people over the years that had these ICD-9 terms, because I'd be curious to see what's going on with their data. And so here's my data, and I actually normalized it a little bit because the number of terms per person increased over the years for some reason. And it wasn't that they got sicker. I think the medical records department just got more, was more complete in how they were coding the patient. So it's a little normalized. But, we can see 785.5, which you're not supposed to use. There was a handful of those. And then we can see cardiogenic shock was thankfully a very low number. And 0 to 5 or 6 cases per year. But wow, look at the good news. We're winning the war on shock not elsewhere classified. So, as many as 40 cases a year, and now it's dropped down to really a negligible amount in 2008. So what's going on? How did we find the miracle cure or prevention for this disease? Well, of course we didn't. What was happening was that now we have a code for all those people with septicemic shock, and that's what that red line really was counting. And but now we count them differently, more accurately, I guess. But the problem is that people that write programs to pull data and say, yeah, I'm going to pull data over the years, I'm going to follow patients, look at these, do statistics. When the ICD terminology changes, or any terminology that's using these non-elsewhere classified terms changes, the meaning of the codes change, and you may not be aware of it. We actually did a little survey of that at Columbia. We contacted people who had used non-elsewhere classified terms in their epidemiologic studies, and we looked at those that had changed due to semantic drift and said, hey, did you realize when you're doing this study that the meaning of this changed over time? And they universally had no idea that this had happened. So now I do want to say, don't confuse NEC with NOS. Easy to do. NOS stands for not otherwise specified, and it really just means they're sort of the generic version. So you could have, if you had shock not otherwise specified, that would be just a more generic term where you didn't know which kind of shock it was when you use a higher level term. So I have no objection to the NOS term, but it's NEC that's a problem. All right, let me stop there and see if there are any questions about all this before I get into the evolution stuff.
Jim, this is Jessie. I have one question. Can you talk a little bit about, there's technical terms for it that I'm forgetting, something along the lines of like post hoc coordination and the pros and cons to making something more specific versus having two different terms that you can kind of combinatorially combine? Okay,
so yeah, so post coordination and pre coordination. And yeah, and there's a desideratum about that in here somewhere, and it's so pre-coordination would mean I took two words or two terms and combined them into a single code because it's a useful construct. So think about pain, for instance. So we have pain, we can have different kinds of pain, but let's just take pain. But then we'll say, well, where is the pain? I say, well, it's in the arm, it's in the leg. Do we really want to have a code for a pain in every part of the body? There'd be thousands of them, right? Pain in the left tympanic membrane, pain in the right earlobe, pain in the left pinky. It's a lot easier to simply say, look, there's pain, and then there's a location for pain. And so that we call that post-coordination, where we take a coded term, pain in this case, and then we have a terminology of locations that we use to modify it. But there are some pains that are kind of special. Chest pain, for instance. So somebody comes in and has chest pain, we want to have it's convenient to have a single code for that because we do things differently when people come in with chest pain. We activate, Emergency medical service. We slap an EKG on them. You know, we start worrying about things like heart attacks and that sort of thing. So sometimes we are interested in these pre-coordinated terms, and so we add them to our terminology. You can think of them as atoms and molecules. So you could say, well, pain and location are atoms, and then chest pain is a molecule. And then you could say, well, we're only going to deal with atoms, and you always have to create your molecules. Then you'll never win that argument, because there will always be somebody who can split your atom into smaller things that he will call atoms. So I don't worry too much about the fact that this happens. The Desiderata number 12 actually is called recognizing redundancy, and it has, I don't have a slide for that, but basically it's the idea that if there's always going to be multiple ways to say things, and I don't know what it's like in SNOMED nowadays, but at one point you could say acute appendicitis, and that was a pre-coordinated term, or you could say appendicitis, and then there was a modifier acute, and you could combine those things to create two codes, or you could say inflammation with location vermiform appendix, and the modifier acute, and so you could say it that way. So there were at least 3 different ways to say acute appendicitis. And I would say that if you have things like formal definitions, then you have a way to figure out when people are talking about the same thing. And sorry I don't have a slide that shows that, but if we have time, I'm sure I can go find one. Does that answer your question?
Yeah, that's helpful, thanks. I suspect that this group will have a lot of things to consider of cases where we have to decide if something should be pre-coordinated or post-coordinated. It's good to recognize that both are okay in different circumstances.
Yeah, you know, it's tough. You know, it'd be nice to say, well, we're going to pick one way to do it and then stick to it. It turns out to be, in the real world, turns out to be really hard to do that sometimes. So good luck. Other questions?
Are there any terminologies out there that do follow all the desiderata?
Yeah. Oh, yeah. I would say SNOMED. In fact, I'm going to talk about that in a couple minutes. SNOMED, LOINC, RX Norm, they do a pretty good job following the desiderata. There are others that are pretty close that follow some of the important things. They may not have formal definitions. Formal definitions are one of the hardest things to do because it's expensive to create a formal definition for everything in your terminology. But they do things like meaningless identifiers and graceful evolution, which I'm going to talk about. So it's better. I would say the ICDs are pretty. They're the poster child for what not to do, and everything else does it better.
Thanks.
Other questions? All right. Okay. So graceful evolution. So graceful evolution is the notion that terminologies have to change over time. They can't be fixed. That is fixed in the sense of static. First of all, you may find a mistake in a terminology, so you need a way to repair that and get the repair out to people that are using your terminology. So you always have to assume there's going to be something wrong that needs to be fixed. Medical knowledge grows, and so you need to allow your terminology to grow with it. And so there are good reasons and bad reasons why terminologies change. So let's look at the good reasons first. So we might have a simple addition. That's, we just found a new term. We might refine something. So we might say, we used to think there was only one kind of this disease, but now we find out there's 3 or 4. So let's create more specific terms. We're not going to throw away the old term because it's a perfectly good term, but we have nuances that we can include if we know about them. I encountered this early on when I was in informatics, and I met Jack Myers, who was the clinical mind behind Internist 1 and QMR, and he had me put a case into his system, into QMR. I guess it was an early version of QMR, and I put in fourth heart sound. And I was very happy that for those of you who listen to hearts, fourth heart sound is kind of a hard thing to hear. And I was really sort of pleased with myself that I had picked up on this fourth heart sound. But Jack Myers said to me, is that a right atrial fourth heart sound or a left atrial fourth heart sound? And that was the first time I ever knew that there was a difference. I mean, anatomically, I could imagine why there would be one. imagine that you could actually tell the difference with a stethoscope, but apparently Jack Myers could. So refinement is something you'll want to do in terminologies. Minor name changes, by which I mean a change in the name that doesn't change the meaning. So my retronym, fixing a spelling, you might decide there's a more conventional way to call things that maybe something more politically correct, whatever, as long as it doesn't change the meaning. Minor name changes are fine. So there's pre-coordination. So we might create a term because we say, it would be really useful to have a single code for this thing that we have been talking about it in multiple different things. So one example would be in culture results, in bacterial culture results, you would test for bacteria, and sometimes you'd find Staphylococcus aureus. And so you would say, okay, I found Staphylococcus aureus. Then you would go and do antibiotic tests on the sensitivity test, and you find out what it's resistant to, what it's sensitive to. And sometimes it would be resistant to methicillin. So you would have this one test that said, well, we got Staphylococcus aureus. And then you'd have this other test that said the sensitivity to methicillin is resistant. Well, methicillin-resistant Staphylococcus aureus is a pretty important clinical condition. And although that's not a subspecies of the bacteria, it was an important enough concept that people created that concept as in clinical information systems as a single pre-coordinated term, so that if the lab noticed this, instead of waiting for you to put the pieces together, they could just go, hey, this guy has MRSA. Disambiguation. Sometimes you notice, and this is fixing a mistake or clearing up a misunderstanding, a term might seem to have more than one meaning, and so you might split it out into two meanings. Or you might have an obsolete term, as we mentioned, non-A, non-B hepatitis, or you might discover that you've got two terms in the terminology that have the same meaning, in which case you want to mark one of them, at least one, as obsolete, and have it point to the other one. Like, don't use this term, use this other term. And then you got to remember, if you're ever going back to search the database for old data, you got to know to use both those terms, unless you're going to actually go back and recode the data. So those are good reasons. Let's see, is there another one? Nope, that was it. Bad reasons. So these are things that happen to terminologies when they're not paying attention. So adding a redundant term. So somebody says, oh, we're missing this term. We need ornithosis. And then you add it, and you find out you have psittacosis all along. In fact, one of my first run-ins with terminology, they put me in charge of Mass General's CoStar terminology when I was a fellow. And the very first day, I added a redundant term because I was looking. They said, hey, we've got acetaminophen and codeine. I'm like, you've got to add that to the terminology. I said, really? You don't have that in there after all these years? You don't have acetaminophen and codeine? And they said, well, we can't find it, and see if you can find it. Well, I went in and looked, so typed in the name, it didn't find it. I did a tree walk down its strict hierarchy and went into opiates and codeine drugs, and then, and I couldn't find it. I said, well, I guess we'll need to add it. And the very next day, I found there was Tylenol with codeine because it was under Tylenol and the word with instead of and it was in the Tylenol part of the hierarchy. And so now I had to add a redundant term on my first day in the job. Major name changes. So look, anytime ICD changes a name of a code, you can almost guarantee it's going to be a major name change. They're going to add some more specific thing to it. So they had term X, and then they don't have another level in the hierarchy because the structure limits the size of the hierarchy. So instead of saying, well, we can't add a child to this, so now we're going to have X type 1 and X type 2, and what they should be is children of type X. But instead, we'll just rename X to be X1, and we'll give it a new sibling, X2. And they do this all the time, and you've got to wonder, what the heck? How are you supposed to compare data over, across the years when they do this? But they do it. Reusing a code doesn't happen too often, but ICD-9 did it because they had a whole area of terminology that they got rid of. I don't know. It was procedures. I think were something like coronary artery implantation. It was a surgical procedure where they would cut or mammary artery implantation. They would try to provide blood supply to the myocardium. Get this, by cutting the internal mammary artery, which runs up the inside of the chest, and implanting, just sewing the end onto the myocardium and hoping the blood would somehow soak into the myocardium. And they would do this test and this procedure, and believe it or not, people would get better. Or at least they would stop complaining about their chest pain because maybe they didn't want to go through another surgical procedure. But anyway, it seemed to work until somebody did a controlled study, a blinded controlled study, where they did a sham implantation and showed there was no difference in outcomes. So ICD got rid of the codes for that procedure. And then later they said, hey, you know, we've got these procedures where they replace batteries in pacemakers. We should, you know, have codes for that. And oh, here's a whole area where they're not using codes. These codes are unused. Let's use those. And it turned out they had been previously used. So happens in my favorite whipping boy ICD. And then changing codes. So sometimes they'll move a term around, like gastric ulcer. They'll move it around because they decide it belongs in a place in the hierarchy. So those are bad things that happen to terminologies. All right, so SNOMED, I guess you guys already know about SNOMED. Maybe you don't know that it started in 1928, the New York Academy of Medicine. So many good things started in New York. And then it was picked up by the College of American Pathologists and Roger Cote and David Rothwell said, hey, let's take this terminology and see if we can code microbiome or pathology slides. And they had these 4 axes: topography, etiology, morphology, function. And they said, now if we can code each of these microscope slides by one term from each of these 4 axes, you'll always know what you're looking for. It was a very novel idea, and achieved a certain amount of success as they went to and created SNOMED in 1979. And then SNOMED version 2 actually is probably still used in some places because it was just so popular for coding pathology specimens. And it was 7 axes, and then they've got up to, I don't know how many axes after that. They created a reference terminology, SNOMED RT, and then they merged with the Reed clinical terms, and they called it SNOMED CT, and that's what we have today. And it's a semantic network with definitions. And there's this US-wide site license, and it's managed by, now called SNOMED International. It was the International Health Terminology Standards Development Organization. But that was, or ITSI-DO, as they would call it. Okay, so here's a SNOMED term, pulmonary tularemia. And it is a multiple hierarchy, so it's both a tularemia and a bacterial pneumonia. And it has finding lung structure, which is a controlled term, and it's got associated morphology, inflammation, and causative agent for enterocellular tularensis. So a very nice formal definition. Now, not all the terms in SNOMED have this, but they've been working at it. It's pretty hard sometimes to figure out what's the formal definition of, say, diabetes. What's the site of diabetes? Is it the pancreas? Is it the bloodstream? Is it the basement membrane? Is it the glycosylated proteins? What is it? What's the actual site of diabetes? It's not so easy to define. All right, one more little story. So there's 1997 at the Ventana Beach Hotel, and I eventually was on the SNOMED. Well, I was a consultant to the SNOMED editorial board, and the College of American Pathologists has a lot of committees. They do a lot of good volunteer work. They don't pay them, so they make sure they put them in good places. And the committees meet 3 times a year. Once a year, they have to meet in Chicago, where the college is. But once every 2 years, they're allowed to meet off continent. And so in 1998, they met in the Carambola Beach Resort in St. Croix. And maybe you'll notice this common fondness for red roofs. So there's the Ventana Beach Hotel. And Kent Spackman was taking over the editorial board from Roger Cote. Roger was retiring, and so he was kind of handing over the reins, and they had jointly put this meeting together, and Kent asked me to present the desiderata. And he gave me a half an hour to do this, but he put me on last on the program. So we were there for 2.5 days, sitting in one of those buildings, looking out at the water, and now it's my turn to talk about desiderata, and I'm the only thing between all these crusty old pathologists and the beach. So I'm thinking, they're not going to listen to this. I'm going to just do it in 5 minutes and get it over with. So I blew through the 12 desiderata in 5 minutes. And somebody said, hey, Kent, why are we learning about these desiderata? And Kent said, well, I'm hoping there'll be a motion to adopt them for SNOMED. I move we adopt the desiderata for SNOMED. All in favor? Aye. Okay, motion passes. And they ended the meeting, and everybody ran out to the beach, except Kent. Because Kent then took that and was able to change SNOMED dramatically. Because SNOMED International, if you look at back then, what it looked like, it was a big mess. It had meaningful identifiers. There was a hierarchy, but it wasn't explicit. So sometimes you would look at these 2 codes and go, is this code a child of that code, or is it a sibling of the code? And Roger would go, well, of course you can tell by the code and by the meaning. Of course, the computers couldn't tell. So Kent changed SNOMED dramatically. He got rid of the not elsewhere classified terms. He made it a multiple hierarchy. He changed the identifiers from these meaningful things that begins with F's and E's and things like that to just these big integers that we see today. It was, I mean, it's unrecognizable except for the actual terms themselves, the names of the terms. That was an amazing thing, and I meant to ask him, did he put me on last on the program so that they would just blow past this and he would be able to do what he wanted to do with SNOMED? So eventually they created ITSY-DO, and ITSY-DO started meeting in places like this. This is a 4-star hotel in Copenhagen. The thing on the left there, and I'm not sure, this boat basin with, you know, like some half-sunken boats, and it was pretty dismal. So the days of the red roofs overlooking the water were over, perhaps. All right, so that's SNOMED. I'll send these slides around to everybody that I sent the invite to, so you have them. People sometimes ask me about the desiderata and different terminologies, and so I kind of threw this together. And plus means that they adhere to it. Minus means they don't adhere to it. And the plus minus means, well, they kind of do, but they're not doing a great job. So for instance, let's look at ICD. It gets a plus for coverage. The reason it gets a plus for coverage is that they gamed the system. They have a code 999.99, disease not elsewhere classified. So technically they have a code for everything that you could possibly want to say, but it's a kind of a cheat. And they have a strict hierarchy, not a multiple hierarchy, so that's why they got a plus minus there. If you look at some of these others, you see RX Norm, Loink, you know, they do a pretty good job on the desiderata. SNOMED. UMLS is not a terminology. It's got lots of coverage, but it is, you know, it doesn't really, for instance, it doesn't have a formal hierarchy that organizes things. It's got lots of is and relationships, but not a real hierarchy, so you'll find cycles, things like that. And it has not elsewhere classified terms, but I can't really hold that against the UMLS because it has all the terms from other terminologies, and if they have a junky term, the UMLS has to include it. So really the RX Norm, SNOMED are your, you know, kind of best bets for coverage of the medical domain. Here's another one. If you're choosing a domain for your terminology, and you're looking, for instance, history of present illness, past medical history, physical exam, and so on, I kind of gave term, you know, it's like 1 plus means, well, it touches on that domain, but you wouldn't want to use it. 2 means, well, it's not great coverage, but if you don't have any other choice, then use that. And 3 means they do a pretty good job, or are really attempting to cover the domain. So SNOMED, you know, wins a lot of the categories. It doesn't do labs as well as Loink. It doesn't do medications as well as RX Norm, but otherwise does a pretty good job. Okay, I'm going to go back now to gender. Okay, so let's imagine a hierarchy of gender terms, and I've thrown this together as my controlled terminology. And if we were all sitting together, or I could see you on camera and you could raise your hands, we could have a discussion about what's wrong with this terminology. There's a lot of things wrong with it. First of all, it's got redundancy. You can see there's male, child, and boy. So you'd say, okay, you know, those are really the same thing. And then it's also incomplete. We see female adult, but we don't see female child. So there's missing terms, incompleteness. We've got things that are misclassified. So a male transvestite doesn't belong under other, belongs under male, I think. And we've got unknown. And unknown is an interesting one because it's got multiple meanings. It's ambiguous. Unknown could mean we forgot to write it down, or it could mean we looked and we couldn't tell. And that happens sometimes, especially newborn males sometimes have underdeveloped genitalia and they can look like females until they have a little chance to grow out a bit. So unknown can actually have multiple meanings. And let's see, anything else wrong here? Anybody see anything else wrong with this terminology? We have no spelling bee champions. So misspelled term, male transvestite is misspelled. Okay.
Oh yeah.
All right. So we could figure out what are all the genders, and you could go to Facebook and they crowdsourced this, and they said, everybody tell us your gender, and we'll collect them in a big list, and then you can pick from that list. Here's the list. 59 genders. Your guess is as good as mine. A lot of these mean. They do have definitions there somewhere. Two-spirit. I like that one. Maybe I'm going to check out that. That's good. I'm not sure what the stars mean, but they mean something to somebody. Gender nonconforming, gender fluid. Gender fluid sounds like something you don't want to step in. But anyway, that's genders on Facebook. All right, so what about, what do we mean by gender? So gender seems so easy once upon a time. Male, female, done. Well, are we talking about genetics? So XX, XY, but then there's, XO, that is you only have only one sex chromosome, three X's, an X and two Y's, two X's and a Y, then maybe there's some other ones in there. So all these variants of genetics, and they have different kinds of conditions depending on, what the makeup is. And so genetically, we might care about these differences because that's a sort of an underlying thing about who you are. Then there's embryonic, sort of how you develop. So there's a thing called testosterone insensitivity syndrome, and what happens is that you have well, you could be a female and have this, and nobody will notice because females don't need testosterone particularly. It makes them have hair where they don't want it, and changes their voice and that kind of stuff. But males do want testosterone, obviously, and if they don't have the receptors, functioning receptors, then they don't develop as males. So they don't go through puberty. They don't get all the changes that you would expect in a male, and so they end up being kind of ambiguous. And so they are often treated, or usually treated with estrogen, so that they develop phenotypically they look female, and they are they're even more feminine than regular females because they don't have that pesky testosterone giving them hair where they don't want it and changing their voice and things like that. So, but they don't have female genitalia or sex organs. They can be altered surgically, but they can't have children. I don't know what their risk for breast cancer is. I've never seen any statistics on that, so I don't know whether they're male or female, but clearly they have a different set of medical issues than somebody who is simply responding to testosterone and has an X and a Y. There are people who go through surgical changes. They may be partial or complete, so different stages of change, and so their physical appearance may be different. And then there's how they're identified, how they identify themselves, who they're attracted to, and then what are we worried about? Why do we care about gender? Well, or sex. Well, of course, we worry. Some people might be pregnant, so we want to prevent pregnancy or assist pregnancy or prevent injury to a fetus if somebody's pregnant. We worry about different risks of disease, breast cancer versus testicular cancer. By the way, the testosterone insensitivity syndrome patients are high risk of testicular cancer because their testes don't descend. So they need to be removed surgically to prevent that. It's a very high risk for them. There's behavioral risks with different kinds of sexual activity. And then, roommates. Who do you put in the hospital? You got two-bedded rooms. Who goes in the room next to you? Is it based on what they look like? Is it based on their genetics? So they might be, if you're a female and they have somebody who has had a sexual, change to a male, is that appropriate to put that person in your room just because genetically you both have bar bodies? I don't think so. So, knowing these distinctions is helpful in figuring out which method you use for doing the classification. Now, Piper shared this with me. He looked up things about sex in SNOMED and found these different sexual orientations, I guess they are. And so we've got sexually attracted men, sexually attracted women, and you can imagine people of different, whatever their other attributes are. Now we're talking about who they're attracted to. Maybe they're attracted to men that look like women, or women that look like men. Or there was a novel I read once where you could change not only your sex but your sexual orientation. That was very confusing. So you could go from being a heterosexual male to a heterosexual female, or homosexual female, or whatever you wanted. And it was very confusing to everybody. So this is some of the things in SNOMED. So that's this was supposed to be easy. This was just, sex or gender. It was supposed to be an easy one. So imagine when we get to things like diseases, how complicated it is. All right, I see I'm at 3:30. I'm going to pull up this last one very quickly. And this is psychasthenia. In 1903, it was a condition in DSM about obsessions. And it had various things called forced agitations. Mental, motor, and emotional agitations were the attributes of this condition. And then it has evolved to have obsessive compulsive disorder, organic writer's cramp, respiratory malfunctioning, malfunction arising from mental factors, skin disorder arising from mental factors, somatization disorder, anxiety, general anxiety, ego dystonic sexual orientation, abnormal involuntary movements, body dysmorphic disorder, anorexia nervosa, whoops, go back, and so on. So psychasthenia has evolved into being characterized in many different ways. So conceptually, the DSM originally had this obsessive compulsive reaction is a psychasthenia, and then the MMPI said that psychasthenia is a personality. ICD-9 cross-maps this to somatoform disorders, and of course it's got the somatoform disorder not elsewhere classified. That little 9 at the end is the giveaway there. ICD-10 cross-maps psychasthenia to neurotic disorders, and specifically other specific neurotic disorders, or specific neurotic disorder not elsewhere classified. So lots of different ways to do it. Let's look at it conceptually what we might have. Well, we have personality or personality disorder. We have psychasthenia. That became deprecated. It was no longer, no longer considered a concept. And now we have all these other things here. And so we might see that they all belong as children of personality. But if we have a database that goes back as far as psychasthenia, then we actually want to make it look like that, so that we can figure out how to classify people into groups and say, no, these people, we're looking at data across the span of time, it would be more appropriate to classify them this way. And I think that's my last slide, except to just say there's this nice NCI term browser. If you're interested in looking up terminologies, SNOMED in particular, but lots of other ones, you can go to this website, and it's very easy to find these terminologies. I've got some suggested readings on the desiderata. And I'm a couple minutes over time, but let me see if we have questions or discussion.
So where did when you start breaking down a term into its component parts, and this is part of the challenge for doing it for mental disorders, the selection of what are the sub-concepts, how does that come to be historically? Either one person's in charge or you do it with a committee. It's often not so obvious how you break these things down. I mean, you take psychiatric disorders. The psychiatric disorder is often defined by a collection of things, and it's not even a simple, well, you have to have at least 3 of these 5 things, and then that's what you are. Sometimes it's 2 of these or 1 of those, or you get these complicated arrangements of findings to define a condition, and so it becomes difficult to say to pre-coordinate that, because then you would have to say, well, let's see, there's the version of this disease where you have 3 of these and 1 of those. And there's another version where you have 2 of these and 1 of those, and then all the different permutations of what those could be. And so you end up saying, now let's capture them separately. We will capture the findings, and then we will look at the findings and come up with a diagnosis based on the findings. And then that diagnosis will have a definition. It could be a formal definition, but it would have to be more than just a list of attributes. There'd have to be some logic to it, right? To say, well, you've got to have this, or you've got to have this before that, and so on. I guess one thing I'm interested in is what kind of constraint does some of the rules of the desiderata impose on an attempt to do a major redoing of a section? Like, I sort of got the sense that, you're not supposed to change terms, or there's a limit to how much you could change because it's going to mess up things that are historical. Is that correct? And does that put a limit to how much change you can make? No. You change what you have to change to capture what you want to say. Sometimes the change is so drastic that you might need to start, say, we're going to create a new terminology because the old one just isn't working. Think about, cancer, cancer classifications come to mind as things that just get, redone. Even tuberculosis and SNOMED or an ICD, just doesn't, you can't translate the old codes to the new ones because they've done it a completely different way. You got to do what you got to do. I think the important thing is to say, how would we represent these old data in the new terminology? How do the terminologies relate to each other? So if I've got this old one, psychasthenia, how does that relate conceptually to these new things? Are these new things really subclasses of whatever that old concept was, or are they really just very different and they have other attributes, and we've decided that's not, maybe this is the appropriate,
organization. And that's something that you need expert opinion on to do. But what I'd say is, don't do what's convenient for the computer. Do what is right conceptually, because it will come back to bite you if you try to take a shortcut and go, well, that other way was really ugly. Because then suddenly you find you need to, merge data across time, and you are stuck. So I'd say it's not easy if you're going to redo a whole area, but we've learned new things. And we shouldn't continue to classify something in one place if we've learned that it really doesn't belong there. I think I saw a question pop up, something about merging SNOMED. Let me see, somewhere on here I've got chat. What is your opinion of combining SNOMED with LOINC and RxNorm called Solar? So I'm not familiar with Solar, but I think that using those three coding schemes in an electronic health record is really the way to go. What I'd say is to avoid using the SNOMED terms that overlap with the LOINC domain or the RxNorm domain. I don't think RxNorm and LOINC overlap, but certainly SNOMED overlaps with both of them. When you get in, and LOINC is great for laboratory, I'm not sure where it falls for some of the other domains and whether SNOMED is better for other diagnostic procedures. So that'd be a little tricky. There are people looking at subsets of these things. So RxNorm, there's there's a subset, I'm blanking on the name at the moment, but there's a subset of RxNorm that's sort of what are typically used. There's a subset of SNOMED that is much better for problem lists. I think they cover the domains pretty well, but I'm not familiar with Solar, and I'm going to have to go look that one up. Any other questions? Okay, well, I hope this was helpful. If you think of questions later, you all have my email address. Feel free to shoot an email, and I'll do my best to answer them.
Thank you very much, Jim.
Okay.
Yeah, thanks, Jim.
All right, when I finish this recording, I'll figure out how to download it and put it on YouTube or whatever it is that GoToMeeting does with these things.
Sounds good. Thanks.
All right.
Okay.
Bye, everyone.